Welcome to the American Liver Foundation's Provider Education Program, increasing your impact with multicultural patients on metabolic dysfunction-associated liver disease with LatinX Physicians of California. I am Ivory Allison, the National Senior Director of Community Impact for the American Liver Foundation. The American Liver Foundation was founded 48 years ago and is the nation's largest patient advocacy organization for individuals with liver disease. We engage over 5 million people each year through our robust education, support, and awareness initiatives and programs. As part of our commitment to the liver community, ALF offers a range of educational programs for patients and providers. You can find more information on our website at www.liverfoundation.org. Thank you to our sponsors, Pfizer, for their dedication, commitment, and support of this program. We could not have done this without you. And a special thank you to our program partner, LatinX Physicians of California. And we would like to recognize and thank our planning committee for curating this program. They did an amazing job, and we thank you. We have a wonderful program for you featuring our wonderful speakers from across the country. We're so excited to have all of them share their knowledge with you today. And so I am so extremely pleased to welcome our moderator today to give you an official welcome, Dr. José Alberto. Welcome, Dr. José.
Thank you, Ivory. This is a great honor, and I want to thank all of you for joining us today. My name is José Alberto Arévalo. I'm a family physician and the founder and president emeritus of LatinX Physicians of California, which is one of only 2 statewide 501c3 community-based organizations in California that is specifically dedicated to advocate for and improve the health of the Latinx communities of this great state. To this end, we are proud to partner with the American Liver Foundation to bring you this important webinar that is dedicated to call attention to what was formerly known as non-alcoholic fatty liver disease, and to convince our audience today that as to the gravity of this chronic condition that affects our Latinx populations to a high degree, as well as other really significant populations. We also want to make you aware of the new name of this condition, which is a metabolic dysfunction-associated steatotic liver disease, or MASLD, to discuss how we might identify individuals at high risk for progression of liver disease, and to share with you what are appropriate interventions to prevent the debilitating consequences from the advanced stages of this disease. During the summer of 2023, non-alcoholic fatty liver disease was renamed by international consensus to reduce the stigma associated with non-alcoholic fatty liver disease, and also to facilitate a shift toward prevention, proactive case findings, and early identification of progressive liver fibrosis. Today, you will learn how MASLD affects individuals with evidence of hepatic steatosis, for example, when found incidentally on an abdominal ultrasound scan, and for those who have at least one cardiometabolic risk factor. You will also learn that MASLD is primarily a metabolic disease. It's really the liver's manifestations of the metabolic syndrome. We will also learn that we have an opportunity to prevent the progression of MASLD to the more inflammatory stages of fatty liver disease known as MASH. MASH, which stands for Metabolic Dysfunction-Associated Steatohepatitis, replaces NASH, or non-alcoholic steatohepatitis. MASH is the most inflammatory stage of MASLD, defined by inflammation of hepatocytes. This stage is significant because MASH carries a risk for progression to fibrosis, cirrhosis, and even hepatocellular carcinoma. So how common is MASLD? Since the 1970s, mortality has fallen from cardiovascular disease, respiratory disease, and even cancer, whereas mortality has risen 4-fold from liver disease. The main causes of liver disease over these years are still, of course, alcoholic misuse, chronic viral hepatitis, and now MASLD and MASH, driven primarily, but not exclusively, by the obesity pandemic. MASLD is actually now the most common liver disorder in Western countries, affecting up to 1/3 of adults globally and up to 90% of people living with obesity or type 2 diabetes. Sadly, MASH is the fastest growing indication for liver transplantation in the Western countries. So I'm very thrilled and honored to introduce our illustrious panel of speakers today by order of their presentations. At the end of Ms. Carwa's presentation, we will have time for Q&A. First will be Dr. Maria A. Lagarde, then Dr. Yvonne Flores, followed by Dr. Nisha Patel, and finally by Fiorella Carwez. So please take it away, Dr. Lagarde.
Thank you, Dr. Arévalo. I'm happy to share the new developments in fatty liver disease with the group. And I'm really honored to be invited for this panel. Let me just allow me to share my screen. Sorry, I think I shared the wrong one. Hold on. Stop here, and I will open up my video, and I will try to share again. 1 second. Share screen, and I will go to the presentation. Okay, very good. And on presentation mode, here we go. All right, thank you. So I will be talking, as you described, about metabolic dysfunction-associated liver disease. And I'll start by, kind of bringing you up to date on some of the changes. As you well summarized, the most important change that happened in the last year is a change in the nomenclature, which is now no longer called MASLD and MASH. And I will tell you as a little bit into the history as to why this happened. So first, as some of my objectives, again, is discussing the new definitions and understanding why this happens. We'll talk about the diagnosis workup, as well as some potential treatment options. And so with that, I'll begin by explaining what NASH was. So NASH, or non-alcoholic steatohepatitis, right, was the older definition for this disease, in which we found steatosis in the liver, which means accumulation of excess accumulation in the hepatocytes. However, to make this diagnosis, you had to ascertain the definition of lack of alcohol. So you had to very well document lack of alcohol consumption, less than 20 grams per day for females and less than 30 for males. And you had to really rule out other conditions or chronic liver disease in order to be able to call it NASH. So it was a diagnosis of exclusion that particularly focused on the lack of alcohol. However, this is no longer the case, right? And so now we're really talking about metabolic associated steatotic liver disease, or metabolic dysfunction associated steatotic liver disease, in two main characteristics. So as you were talking about, metabolic dysfunction associated steatotic liver disease and MASH. And I'll talk a little bit about these definitions and what they mean. The reason is now these are no longer diagnoses of exclusion, and we're focusing on the pathophysiologic mechanism of this disease, highlighting the relevance and the importance of metabolic syndrome as part of the diagnosis of this disease, and recognizing that even though alcohol can play a role in the progression of this disease, you no longer completely have to exclude it. So another few terminology that we need to be made aware before we move forward with this presentation is fibrosis. When we talk about fibrosis, we really talk about accumulation of scar tissue in the liver over time, and usually happens in patients that have had any evidence of active inflammation, specifically in the setting of MASH, is active inflammation of the liver that then leads to fibrosis. It goes anywhere from 0 to 4, and 0 is a normal liver without any evidence of scar tissue, and 4 is the evidence of more advanced liver disease or cirrhosis. Then we talk about cirrhosis, which is basically the culmination state of more advanced fibrosis, in which you start to have nodularity formation, as well as complications of liver disease, including changes of portal hypertension. And lastly is HCC, or hepatocellular carcinoma, which you'll see abbreviated this way, which is primarily liver cancer coming from the hepatocyte cells, and can happen specifically in MASLD and MASH in patients both with cirrhosis and without cirrhosis. However, in cirrhosis, it continues to be the more likely scenario is in patients with cirrhosis that then develop HCC. So going back to the basics of what is steatotic liver disease, well, as we discussed, is the accumulation of fat in the hepatocytes. And usually to make this diagnosis, we talk about at least 5% of the hepatocytes have to show steatosis. So if you look at here on my left, you will see a normal liver biopsy with regular hepatocytes and really no evidence of these fat globules, as you are seeing in sample E, where you're seeing now the hepatocytes are present and you're seeing their nuclei, but then you're seeing this globules accumulation of fat in the cytoplasm. And this is what we call steatosis. The difference is when we start to call MASH, and that is the presence of active inflammation. And if you see in this last example here in F, you'll see in the middle that you start to see evidence of active inflammation or inflammatory cells. And so again, the definition is MASLD, which is the presence of fat. And the way I like to explain it to my patients is there is excess fat in the liver. It usually takes more than 5% of the hepatocytes, but it's just sitting there. It's not causing any problems. Once it starts to turn into active inflammation, cellular injury, you see ballooning hepatocytes, and you start to see the presence of cirrhosis or advanced fibrosis or cirrhosis. That's when you call it MASH. And that's the main difference. Now, MASH is still a pathologic diagnosis. You have to have a liver biopsy in order to call something MASH, because you need to see that inflammation and hepatocellular injury. However, there are things that can point us towards active inflammation, like elevated AST or ALT. However, to make the definitive diagnosis, it still remains a biopsy diagnosis. I'd like to talk a little bit about the progression of disease. So from a healthy liver to fat accumulation, I'll tell you that as we've discussed before, the prevalence of this disease is rapidly rising in the US, together with the rapid rise of metabolic risk factors, including the obesity epidemic in the US. So in the general population, we suspect MASLD, or just fat accumulation, is about anywhere from 15 to 40%. And I'll show you the most recent data in a minute. But then of those patients, 40% of the US population, about 5 to 10% may have evidence of MASH or active inflammation. And then so MASH would then be active inflammation or the presence of fibrosis. Of those, patients have an increased cancer risk, as well as the possibility of developing fibrosis in about 1 to 2% of the population, with now advanced cirrhosis. So of the 40% of the US population that have the presence of steatosis, about 1 or 2% of those will have cirrhosis at the time of diagnosis. Now, it's important to recognize that symptoms may occur in patients who either have MASLD or MASH. However, they may also be asymptomatic. So symptoms may be very vague, such as hepatomegaly, fatigue, abdominal pain, nausea, mild elevation of their liver enzymes. However, once they have more advanced disease, more advanced fibrosis, then these are patients who present with potentially decompensated liver disease, but there's a significant period of this time when they may be completely asymptomatic. It's also important to recognize that hepatic steatosis is not alone, right? As part of the metabolic syndrome, it comes associated with cardiovascular disease, both heart conditions as well as cerebrovascular accidents. The presence of diabetes is very important to recognize, CKD. Obviously, as part of the metabolic syndrome is hyperlipidemia, but also there are other conditions part of kind of associated to the metabolic syndrome, such as polycystic ovarian syndrome, sleep apnea, malignancies of other etiologies that have all been associated with all the conditions of the metabolic syndrome. And it's important to recognize that these patients are very complex and can have a multitude of these symptoms. Now, recognizing symptoms of advanced liver disease becomes very important, but hopefully we can prevent these things from happening if we recognize these patients early. So as we know, the presence of jaundice or pruritus, the presence of variceal bleeding or ascites, as well as coagulopathy, are signs of more advanced liver disease and portal hypertension. Then you have evidence of more synthetic dysfunction like hepatic encephalopathy or confusion, as well as liver cancer, which at the point of diagnosis of cirrhosis, they should be screened. Other things that we can see, you have them here summarized: muscle cramps, irregular menstrual bleeding, gynecomastia, spider angiomata. So it's important to recognize these features because some of our patients will present on more advanced stages of disease. A little bit about epidemiology. So again, it's the most common cause of abnormal liver tests in the United States nowadays. So it really takes up almost, more than 50% of my practice on a day-to-day basis is patients who present with mild elevation of liver enzymes and a workup that reveals some level of steatosis. And again, the prevalence in the US is rising and is expected to continue to rise due to the obesity epidemic, about 25% of adults, but could be way higher than that. Many people with type 2 diabetes, have both MASLD and MASH, and these numbers are also very concerning, as well as children. So MASLD and MASH are greatly increasing in children due to the obesity in pediatric population, and it could be as high as 10% of US children. So as they age out and into the adult population, we're going to see this disease much more commonly. So this is the most recent data from Dr. José in 2023, published in the Hepatology journals. And in North America, the prevalence of still called NAFLD in some of our literature, but MASLD is about 31%. But if you look at the Latin America data, it's as high as 44%. So close to half of all Latin America has a component of MASLD. Some of the more concerning features is, well, we talked that MASLD or MASH, the presence of steatosis can just be, the fat can just be sitting there not causing any problems. However, we start to worry when it causes active inflammation, so MASH, when it has the presence of fibrosis. And so if you add to this data the combination of the presence of diabetes, so in patients with diabetes, how many of them have MASLD or MASH? So that can be as high as 68% in the United States. Those with active inflammation, so MASH, as high as 67%. So really high numbers. But most concerningly, and I'll tell you why, it's patients can then have almost half of these patients with diabetes and presence of steatosis are at very high risk of fibrosis. So almost half of your patients with both diabetes and MASLD will have at least F2 fibrosis and will need more advanced care. There's also significant disease disparities. So this is from a pediatric trial published as part of ASLD 2022 and later became a formal trial. They look at social determinants of health and the impact on morbidity and mortality in patients with fatty liver disease. And so they looked at 200 pediatric patients with MASLD in New York, and they mapped it based on their socioeconomic status, census data, and compared to both New York and national data. So without getting too much into the details, if you live in a low resource neighborhood, you are at increased risk of progression of disease, higher fibrosis, mortality, as well as the incidence of cirrhosis and cardiovascular disease. And this, of course, is paired with, unfortunately, with racial minorities such as Hispanic and African Americans. So it's more likely to impact this specific population. Again, as Dr. Arévalo discussed before, it's becoming one of the most common reasons to transplant patients in the United States. And this is the most recent data from our UNOS transplant data that patients looking for liver transplant, again, alcohol liver disease is rising quite rapidly with the advent of dual, direct antiviral agents for hepatitis C. Hepatitis C has quickly fallen, and alcohol has become the main reason for liver transplant. However, the blue line here, the clear blue line, which is NASH or MASLD or MASH, is rising rapidly and really becoming the second most common reason. Now, for patients with cancer and MASLD, that has become the first reason for transplanting patients is the association of MASLD and cancer. So definitely something to be considered. And this brings a myriad of concerns from the transplant world, which is these patients are sicker. They have much more comorbidities based on what we discussed before. And there's also, a lot more of cancer indications. And these patients tend to be with a lot more morbidity and mortality. They tend to be older based on the disease progression. And so it really brings up some concerns for the transplant world. So the term has changed, right? And so now the idea was to create an umbrella term that took all the patients with steatosis or fatty liver, no longer called fatty liver. So it's important to try to explain and educate our patients that even though we're explaining it as fatty in the liver, it's now called steatotic liver disease. So the big umbrella term is now SLD or steatotic liver disease. And this will be divided into 5 different categories. The most important ones to know are alcohol liver disease, which is now part of this family, and MASLD or metabolic dysfunction-associated steatotic liver disease. But then there's a new category that was created that was right in the middle, which is MET-ALD, which is the combination of metabolic liver disease, metabolic dysfunction-associated MASLD, and alcohol. And this is a brand new category that is important to recognize, and I'll tell you why. But you also have to rule out specific etiologies of liver disease. And so it's important to know what other things can cause steatosis that you should think about and test for. So again, we talked about the definition. So how do we make this definition? So we're seeing the presence of steatosis with or without active inflammation, plus one or more of these metabolic risk factors. And that can be excess weight, so BMI or weight circumference that's high, glucose intolerance in any way, shape, or form, either on treatment, fasting, impaired fasting glucose tolerance, or the diagnosis of diabetes or prediabetes, high blood pressure, or on treatment, hypertriglyceridemia, or high cholesterol. And really, you need the presence of steatosis and one of these metabolic risk factors in order to make diagnosis of MASLD and MASH, because again, it's no longer a diagnosis of exclusion. Let's talk a little bit about the presence of alcohol, right? Because before we had to kind of rule it out. Well, that's not the case anymore. We still want to consider alcohol that could be playing a role, and we want to make sure we ask our patients appropriately. But if you see here, so patients are still at risk, even if they drink a small proportion of alcohol. So MASLD or MASH, these patients tend to have a very slow progression of fibrosis, and their risk overall tends to be low for morbidity and mortality and risk of decompensation. Patients who drink, who are better characterized as alcohol liver disease, and I will guide you to these numbers. So weekly alcohol intake of 350 to 420 grams of alcohol a week, or 50 to 60 females and males of daily alcohol intake characterize alcohol liver disease. But all the patients in the middle are potentially at risk for MASLD and increased alcohol intake. And these patients don't have the slow progression of MASLD MASH. They have faster progression, but not as fast as patients who primarily present as alcohol liver disease. And so this is going to be coming up a lot more in the hepatology and hopefully in the global literature to try to recognize these patients and identify additional risk factors of this very specific group of people. Other things that we should think about to rule out as causes of hepatic steatosis, so viral hepatitis, specifically hepatitis C with genotype 3, drugs that can cause the presence of steatosis. You may be aware of steroids, valproic acid, tamoxifen, methotrexate, or amiodarone are common reasons, and they should always be thought about and evaluated, or specific etiologies of steatosis, such as hemochromatosis, Wilson's disease, or alpha-1 antitrypsin, amongst others. I wanted to bring to the point that some patients we need to consider for steatotic liver disease are those with genetic polymorphisms. And this is not yet in the clinical world. We unfortunately not yet test for specific genes, but it is important to know some of them because they might be available clinically soon. For example, the most important one to recognize is PNPLA3, which has been widely associated, especially in the Latino population, with the presence of steatosis and rapid progression of disease. And this actually might be a clinical tool that we'll have soon to test our patients at high risk. Why is it important to recognize in our Latino populations? Well, because of this. So patients are at a high risk. We saw in our, in our epidemiology slide that Latin America and, in general, the Latino population have a much higher risk of having steatosis, but also of progression of disease. So definitely a higher progression. Nearly 1 in 4 Hispanic has MASLD, and we saw maybe as much as 1 in 2 of them when compared to other racial minorities. And both Hispanic men and women have a chronic liver disease rate that is twice that of the non-Hispanic population. So it doesn't only affect patients that they're more likely to have fatty liver, they're also more likely to have fast progression of disease, and they're also more likely to have advanced disease at the time of presentation, together with other metabolic risk factors. So this is a nice summary here based on the race and ethnicity. So patients presenting as normal, moderate, or severe. And again, bringing both the Mexican and Hispanic populations together, higher prevalence of steatosis overall, but of those, higher prevalence of having more advanced disease at the time of presentation with both moderate and severe, as well as looking at the Latino population with significant proportion of metabolic risk factors, including low HDL, high triglycerides, as well as the overall metabolic syndrome diagnosis. So definitely issues for concern. We talked about some of this. So what are these risk factors that concern the Hispanic population? So again, the PNPLA3 gene variation is highly associated. Our food intake with carbohydrates and added sugars that is high in our diets, genetic backgrounds, as we talked about, the lack of physical activity, and the presence of metabolic syndrome, which is quite common, as well as the obesity epidemic. So all these things should be brought to concern. I want to bring this slide back because now it's important to recognize, like I said, patients who are at increased for fibrosis. And this is going to move forward towards the how do we evaluate these patients. So obviously we want to make sure we know which patients are cirrhotic and need more advanced care, but really is focusing on assessment of fibrosis. And why do we care? Well, because fibrosis, the staging of fibrosis is associated with the development of more severe liver disease, but also other problems like cardiovascular disease and even healthcare costs. So fibrosis is a very important marker that needs to be recognized. And the new guidelines recommend screening, which had never been done before. So the recently published guidelines from last year for fatty liver disease recommend screening patients at especially high risk, for example, diabetics, as we talked about, medically complicated obesity, so those with obesity and other metabolic risk factors, patients who have metabolic syndrome and drink alcohol, so this group we're talking about of MASLD, as well as first-degree relatives, which again had not been on the screening guidelines before, but has become an increasing point of study. And those at the highest risk, so we know that postmenopausal Hispanic women tend to have a very high risk and should probably be screened more often than their general population, although the frequency is not yet identified. And those with genetic components, and again, this points towards that in the future we'll be using some sort of genetic analysis to figure out who to screen. How do we identify steatosis? So there's multiple ways. First step is to, if you find somebody who has been described as steatotic, those patients should be assessed. There's multiple ways. For time purposes, I'll tell you that an ultrasound can tell you, a CAT scan can tell you, and an MRI as well. So look for those key features. But there's also, once you identify fibrosis, and you've kind of done a basic workup to make sure things are, that you're not missing something like a viral hepatitis, chronic viral hepatitis, then you should do some form of fibrosis assessment. And that has become kind of the leading goal, is to identify patients at risk that you've known that now have steatosis on some form of image, and now you are going to think about fibrosis. So if a patient has a non-invasive test, such as a FIB-4 score or an ELF score, and the FIB-4 score is easy, readily available, can be done with labs that you probably already order for your primary care practice, including H, AST, and ALT, and platelets. This is a very good screening test that you can use to determine which patients have fibrosis and who needs to be referred for higher level of care or additional testing. So a low score, less than 1.3, rules out advanced disease and can be followed as long as you continue to focus on their metabolic risk factors as an outpatient. Higher than that, these patients should have additional evaluation. Now, what other additional evaluations are there available? And one of them is the ELF test. So enhanced liver fibrosis test, it uses these three different biomarkers. So hyaluronic acid, procollagen, derivatives of the proteins, as well as a proteinase type of enzyme. And it's a similar pattern. It's a non-invasive test that you can do on regular blood work. If it's low, it can very well exclude fibrosis. If it's very high, it can, like 11, at the level of 11.3, it can rule in cirrhosis. So you could be making the diagnosis with high sensitivity and specificity. And in the middle are those patients who you should continue to work on. And then lastly those are the non-invasive testing. The more invasive testing, such as elastography, is a test that most hepatologists now would have available in their office. And it's a test that helps assess the level of scar tissue or fibrosis based on the stiffness of the tissue and the way the sound waves travels through the liver. So the faster the sound wave travels, the faster the speed will be, the stiffer the tissue is. So the higher the numbers, and I'm going to be looking specifically at the KPA score or velocity, that number, the higher it is, the more likely you are to have advanced fibrosis. And it's very well validated from assessment of fibrosis in liver patients. So who still needs a liver biopsy? Well, if you have other potential etiologies like persistent elevation of liver enzymes, or you're concerned for autoimmune liver disease playing a role, or Wilson's disease or hemochromatosis, those are patients you should consider doing a biopsy, or sometimes in patients who you're considering a clinical trial. But most importantly nowadays, it's used for patients who all this non-invasive testing are not all lining up. And so if you have a FIB-4 score that's suggestive of more advanced disease, but you did alternative testing and maybe your ELF score is one way and your FibroScan is one way, then those are the patients you want to consider a biopsy, because again, identifying advanced fibrosis is really important to plan for treatment. And then lastly is, so like I said, it's important to recognize the presence of inflammation, rule out other diseases, and then establish the presence of fibrosis. Because again, you want to rule out those patients that are low risk, that can continue to be followed up in the primary care setting and can have risk factor modifications as the primary team, or those at high risk, in which case they need specialty care. So the guidelines were very specific at going through this, and I kind of went over this already, but patients with low fibrosis score can, be followed up in the primary care setting as long as you continue to address their metabolic risk factors. And depending on the presence of diabetes, it will determine the rate at which you do it. Those patients who have elevated signs of fibrosis, then they go to additional testing like transient elastography or ALF testing. And based on those results, again, if you're able to rule it out and everything fits, they can continue to be seen in the primary office. But if advanced fibrosis is suspected, then these patients, we usually see them in the specialty clinic. We want to review all the testing and consider even more advanced testing. So there are things like MRI with elastography that can better assess elastography, better assess fibrosis, or finally decide on a liver biopsy. And there are markers of kind of more advanced settings where you would say, okay, this patient has cirrhosis. And it's in this red square here. So very high FIB-4 scores, elastography or ELF testing, obviously images suggesting of cirrhosis or portal hypertension, or a biopsy proven cirrhosis. And so those patients probably don't need, just need to continue to follow up because they now have more advanced disease. So the biopsy could also help you figure out how often you're going to see these patients, prove the advanced fibrosis, consider treatment, which is our goal, right, is to prevent progression, and then also consider patients for clinical trial. And then lastly,
Dr. Maria, 1 minute left.
Go ahead. Yeah, and then so that would be the presence of cirrhosis is confirmed, and then you want to plot them in. And lastly, I just want to touch base and say that we have treatment for this disease, so you recognize them and you want to treat them, and the treatment starts, it's reversible, and there's all these lifestyle modifications. But I want to bring your attention to this new drug, which is resmetirom. It's now available. Previously, we had all these options, but now resmetirom is the new drug that's available for treatment of this disease. Sorry, I'll just move forward to that slide really quick. And basically, it can prevent fibrosis. It can reduce fibrosis by 1 stage and stop inflammation or steatosis. And so it's important to recognize that this is a new approved drug that we should be considering in patients with active inflammation and fibrosis, proven fibrosis, because it will help reduce the progression of disease. And so with that, I want to make sure that you're kind of familiar with the data. Decrease in fibrosis, 24% of patients on the drug, and 29% resolution of NASH or MASH. So really key in this, in the treatment of this disease. Sorry about the little bit of delay there. Okay, and I think that's all I have for now.
Thank you, Dr. Flores.
Great. Thank you so much for that amazing presentation. I'm going to try and share my screen, right? Oh. All right. Is this sharing?
Yes, just put it in presentation mode and you're good.
All right, let's see. Here we go. How's that?
Perfect.
All right, thank you so much. Well, good afternoon, everyone, and thank you for the invitation again to participate in this important webinar. Today, I'll be sharing a brief overview about some MASLD-related research that I and other investigators have conducted. And this is a lot of information, just like in Dr. Lagarde's presentation. So please forgive me if I speak fast, but fortunately it's being recorded, so you can go back and review the slides and the information. All right, so thank you to, as Dr. Lagarde mentioned during her presentation, there's different factors that contribute to risk of liver disease, including not NAFLD or MASLD now, chronic hepatitis, alcoholic-related liver disease. But this slide shows how it is that MASLD has become the primary contributing risk factor for the development of cirrhosis in all racial and ethnic groups, as you can see in this black box, except for American Indian Alaska Natives, who have alcohol as the main contributing factor. And it's the same case with liver cancer, which is with MASLD being one of the main contributing factors to the development of liver cancer among whites and also Latinos. So one thing that I find fascinating is how it is that obesity, the rates of obesity in the United States are pretty similar among Latinos, whites, and African Americans, with African Americans having the highest rates of obesity. And these are the most recently available rates of MASLD and obesity in the United States. But while you can see that obesity is similar in these three race ethnicities, the rates of MASLD is highest among Mexican Americans, which is in this darker blue bar, compared to the other race ethnicities. And it's similar in Latinos and whites, but it's much lower among African Americans, who actually have the highest rates of obesity. So one of the things that I'm interested in, because I'm from Mexico, is why it is that liver disease is such an important cause of death and disability for Mexicans in Mexico, but also in the United States. As Dr. Lagarde mentioned during her presentation, chronic liver disease is the 8th cause of death for Latinos, but is not for non-Hispanic whites or other race ethnicities in the United States other than American Indian Alaska Natives. And in Mexico, it's the number 4 cause of death. So it's an important cause of death. And the main contributor to this problem is MASLD. As you can see in this slide, Mexico has the highest rates of cirrhosis in Latin America, and it also has the highest prevalence of MASLD. So this is a major issue among Latinos, which I know is a large proportion of patients in California. And so one of the reasons why a hypothesis that I have in my research for why it is that Mexican Americans have a higher rate of liver disease and MASH and MASLD is because they have a genetic composition that is different. And so this slide shows a paper that was recently published that showcases differences in genetic admixture among Latinos and how different and substantial the genetic variation is between Mexican Americans, who are showcased on the top, and Puerto Ricans, who are on the bottom. While Mexican Americans have a much larger proportion of Native American genetic admixture, persons of Puerto Rican descent have much more European and African genetic admixture. And as Dr. Lagarde mentioned during her presentation, Mexican Americans also have a higher prevalence of PNPLA3, which is a genetic variant that has been associated with NAFLD. And so this next slide shows what I just said, which is that there is a genetic association, a strong genetic association between NAFLD and specific genetic polymorphisms. And so these are just a few studies that have, there's many, but few studies have focused on Latinos and their genetic risk of NAFLD and MASH. And I also wanted to point your attention to this recent study that was published just this month or last month in Clinical Gastroenterology and Hepatology that investigated the association between PNPLA3 obesity and heavy alcohol use in cirrhosis patients, which increases their risk of liver cancer. So the combination of risk factors, which Dr. Lagarde also mentioned, is really important to also be considering, even though the focus of today's presentation is on MASLD and MASH, it's important to also think about how it is that patients with obesity are also drinking and how that can contribute to their risk. So one ongoing MASLD study that I'm involved in that was recently funded is the genetic and environmental risk of NAFLD-related liver cancer in all Latinos, which we refer to as the genial study. And so what we're hoping to accomplish in this study is investigate the determinants of liver cancer and disparities by having a sort of broad view that includes genetic factors, environmental factors, and also clinical factors to inform more of a precision medicine approach to liver cancer risk among all Latinos. And so this is with my collaborator, Dr. Patricia Jones. We will be enrolling, first we'll be conducting a GWAS study. That'll be the largest GWAS study of NAFLD and MASLD to date, with over 105,000 patients and controls. And this will include all races and ethnicities. And then we will also, at our 3 sites, which are the University of Miami, UCLA, and the University of Puerto Rico, we plan to enroll 750 Latino patients with MASLD and MASH, cirrhosis, and HCC, and 750 Latino controls to identify known and novel MASLD-related genetic variants, as well as gene-environment interactions. And so we're hoping that we already have enrolled Latino patients from over 26 countries. So what we're hoping to do with this study is to incorporate genetic analyses into clinical care, which is something that Dr. Lagarde also mentioned during her presentation, which is a new area of research that is hoping to advance the care of these patients by including their clinical information, as well as genetic information and environmental factors that include the social determinants of health. And so as part of this study, we're hoping to develop a risk prediction model that's more comprehensive to identify patients who are at greatest risk of developing complications of liver disease and target and who could be potentially targeted for clinical trials for new medications and who are at highest risk. So another study that I'm involved in here at UCLA, which I'll just go through very quickly, is also examining racial and ethnic differences in liver disease risk factors using EHR data. And we also have looked at metabolic dysregulation and risk of MASLD among Mexicans. And what we found in our patient population, which comes from a primary care cohort of over 280,000 UCLA patients, of which almost 30,000 have been identified to have liver disease. And this is sort of like a demographic distribution of these patients. But what we found, and which is important because this is, real life research here at UCLA with a large number of patients, is that the largest number of patients are in fact who have MASLD at UCLA are Latino. And so you can see this blue bar here that I've highlighted with this arrow. The risk factor for liver disease by race ethnicity is highest for MASLD is Latinos. And in terms of the metabolic dysregulation study that we conducted was with 100 cases of MASLD and 100 healthy controls in Mexico. And what we did was we analyzed lipidomics, the blood of the cases in the control. And we identified that although none of the top 20 lipids that we examined, which we did something like 1,000 different lipids, none of them were able to identify the difference between a case and a control that well. Once we combined them and created a panel of 10 lipids, we were able to predict case or control status better than with a sensitivity of almost over 80%. And these results have implications also for like the identification of patients who are at greater risk of progressing in their disease. And same thing with the metabolomics study that we did with over 100 different metabolites. Individually, none of the metabolites were as able to predict case control status, but with a panel of 10 metabolites that we were able to identify, we were able to differentiate between cases and controls using up to 90% with a sensitivity of up to 90%. And this is just very quickly, also, this is my last slide, just shows the some other epidemiological research that I'm involved in that shows the projection of mortality from chronic liver disease in Mexico and the US over time. And so the blue bars are men and women in Mexico and this is using World Health Organization data for liver disease mortality over time. And you can see that over time in Mexico, male, which is the top line, males have had the highest prevalence or mortality from liver disease, as well as Mexican females, but that's changing. And over the next 20 years, it appears that, or our results indicate that liver disease in the United States is actually going to become, the mortality due to liver disease is actually going to become higher in the United States, particularly among females. And so females over time are going to have the highest rates of mortality due to this disease, which is something that as clinicians you should also be aware of. And also this on the right is data that we've analyzed using NHANES data, which is a nationally representative sample in the United States, which showcases the prevalence of heavy or binge drinking among by race ethnicity. And as you can see, Latino males have the highest prevalence of binge or heavy drinking, as well as Latino women. So that's also something to consider as you think about patients with MASLD, is also the potential risk for alcoholic liver disease. And these are my collaborators in Mexico, and that's the end of my presentation. I'm sorry that was so quick, but stop sharing.
Thank you, Dr. Flores.
Thank you.
Awesome. I'm just gonna share my screen. Okay, sorry. Oh my gosh, my desktop is it's crazy. Lots of articles that I need to read. So hello everyone, I'm Nisha Patel. I am actually an obesity medicine doctor, also a clinical lipidologist, and I have a background in culinary medicine. And I have a pretty unique practice for medical weight management, obesity medicine. It's actually housed in our transplant department. So I actually take care of pre and post-transplant patients and many patients with MASLD. And so I'm going to give a whirlwind, quick overview of some lifestyle and dietary strategies to help with the management of MASLD. Let me just actually get into presenter mode. Can everyone hear me okay? There's an issue. Let me know. Perfect. Okay. So like I said, this is a high-level overview. Happy to share my slides if they're helpful for anyone. So a couple of objectives. I'm going to talk a little bit about energy balance and weight loss, go over a few dietary components, specifically macronutrients like carbs and carbohydrates and fats and their role in MASLD, talk a little bit about coffee consumption, and then the Mediterranean dietary pattern, which is something that's been studied for the treatment of MASLD. So to no one's surprise, and what we've kind of heard about here from the other presenters, is that weight loss or the treatment of underlying obesity can be incredibly beneficial for individuals with MASLD. We do know that even just a 3 to 5% total body weight loss can actually help with improving hepatic steatosis, but typically need a larger amount, greater than 10%, to start improving markers of MASH and fibrosis. It's important to remember there's no one-size-fits-all approach when it comes to the weight management piece or treatment of obesity. We really have to take into account individuals' eating behaviors and meal patterns, their cultural backgrounds, their resources. Many of my patients are on Medi-Cal, they have limited resources, and so a lot of that has to be taken into consideration when we're talking about treatment. When we look at national guidelines or worldwide guidelines about the treatment of MASLD, we see that weight loss is typically recommended, usually anywhere between a 7 to 10% of total body weight loss. And there is some evidence that a Mediterranean dietary pattern, which I'll go over at the end, can help with improving MASLD even independent of weight loss. So let's talk a little bit about fructose. This actually comes up a lot in conversations about MASLD. The liver does, handle fructose in a unique manner comparatively. It's important to understand that there's really not a lot of food sources out there that we're just eating like fructose by itself. So when we're thinking about ultra-processed food, the fructose is actually combined with glucose to make sucrose, or it's present in high fructose corn syrup, which is a misnomer because high fructose corn syrup actually has almost, depending on the percentage, almost equal components of fructose and glucose. And I think we can all understand that, eating fructose and fruit compared to, drinking sucrose from a soda, that's going to have different cardiometabolic effects, especially when consumed in excess. And that's the other thing I want to mention is that a lot of the studies that have looked at the deleterious effects of fructose first come from rodent studies, which they actually handle fructose a little bit differently than we do as humans. When you look at human outcome trials, it's really important to know that when we're talking about isocaloric substitution, so if we're substituting fructose for another carbohydrate in a controlled energy balance, we really don't actually see deleterious effects in MASLD, but when we actually are consuming it in excess, so in addition to baseline calorie intake, that's when we start to see, deleterious effects in markers of MASLD. And so really important to understand that the source of dietary fructose matters. I think that, we kind of unfairly sometimes demonize fruit out there. The majority of Americans are not consuming enough fruit anyways. And so it's kind of hard to blame fruit for, some metabolic problems. And it's not the same thing as drinking soda or eating Pop-Tarts or cookies. Let's talk a little bit about dietary fats. There are a wide range of dietary fats that we consume in our food supply. In general, when we talk about dietary fats that are potentially beneficial for MASLD, we're talking about the unsaturated fats, that's mono and polyunsaturated dietary fats, especially from food sources that are plant-based, but also marine sources as well. And we typically want to work on limiting the saturated fatty acids that can be deleterious to individuals that have MASLD. So again, looking at substitution studies where isocaloric substitution of omega-6 PUFAs for saturated fatty acids. This was a study that looked at individuals with abdominal obesity. About 15% had type 2 diabetes, and they were asked to keep their dietary fat the same. Their overall calorie content was the same, but they were just varied in the type of fat that they were eating. So one group was eating saturated fat from mostly butter, and then the other one was polyunsaturated fat. This particular study gave the participants some of those foods. And as you can see, when individuals are consuming more saturated fat, or especially in excess, they do have a change in liver fat compared to actually improvement in liver fat based on MR imaging when they're consuming the omega-6 PUFAs. It's not entirely clear why saturated fat can have a deleterious effect on the liver. It's thought to be due to ceramide production, which is this harmful substance that can actually increase hepatic insulin resistance. So it's just an important guideline to recommend. This is a handout from the National Lipid Association, which I think is really great to kind of break down the dietary fats and what food sources contain them. So let's talk a little bit about the Mediterranean dietary pattern. So first off, the Mediterranean dietary pattern, it's not like this confined, like this really strict, well-defined dietary pattern. It kind of just describes a pattern of eating in a certain subset of countries that are around the Mediterranean region. I always tell patients there's not just one Mediterranean diet. It's really a plant-forward dietary pattern that actually is in line with a lot of our national and international dietary guidelines where, we really want to emphasize incorporating more of those plant foods. If individuals are eating animal products, they're trying to, really stick with the non-fried fatty fish or lean poultry, low-fat cheese. It's really a pattern of eating, and it can actually be applied to a wide variety of cultures. I'm South Asian, and there's been kind of this, like for instance, in the traditional Mediterranean dietary pattern, I should say, extra virgin olive oil is really emphasized as the form of fat, but there's been some studies kind of looking at like mustard oil in India that could be a form of monounsaturated fat that can be included in a dietary pattern that is like culturally sensitive. So when we're looking at the Mediterranean dietary pattern and also its effect on MASLD, we do see that there are some improvements in hepatic steatosis in certain studies with Mediterranean dietary intervention itself, but it's not as strong as calorie restriction, which usually results in weight reduction. So again, there is some evidence that eating a more plant-forward dietary pattern may improve markers of MASLD, but it's definitely something that's more strongly seen in calorie restriction. Coffee consumption comes up a lot. Just for the sake of time, I'm going to kind of get to the point that when you look at studies in this particular, it's called an umbrella review of systematic review, and several studies that are systematic reviews and meta-analysis, where coffee consumption seems to be favorable is in areas where it may improve liver fibrosis. As far as prevention of MASLD, consuming coffee by itself, and this is, black filtered coffee. This is not our Starbucks lattes or our frappuccinos. these are, this doesn't have a bunch of added sugar or cream to it, there does seem to be some potential benefit. Usually I've seen like 2 to 3 cups a day quoted in literature. So in conclusion, just to really hit the high points of, what could be beneficial for patients from a dietary and lifestyle category of improvements in MASLD. Calorie restriction by far leading to weight loss really can lead to significant improvements in MASLD and should remain the cornerstone of treatment. That's something that I work really diligently with my patients about. Fructose appears to be more deleterious when it's consumed in excess, and it's really important to understand what the food source of fructose is. Like, again, not comparing fruit to a soda. Excess consumption of saturated fatty acids can be deleterious. I do see this in some of my patients that are pretty adamant that they want to follow like a keto diet, which if you're familiar with that, typically is a higher fat dietary pattern. Typically, individuals, the way it's usually consumed, consume higher amounts of animal fat. And I have seen clinically that they don't have as much improvement in their MASLD because even though they might have some degree of weight loss, they just don't have as much improvement. And I definitely don't encourage that dietary pattern for people with MASLD, but again, trying to honor my patients and their preferences and really try to work with them one-on-one to come up with the best plan for them is really important. But in those that are really adamant on following it, they don't seem to have as much benefit. There's evidence that Mediterranean dietary interventions may improve MASLD with some degree of effect independent of weight loss. There's some evidence that coffee consumption can potentially reduce liver fibrosis in patients with MASLD. And then this combination of a plant-forward dietary pattern like the Mediterranean diet and calorie restriction might be superior to improving MASLD from that standpoint. Oh, don't forget about resistance training and aerobic exercise. I know this was supposed to be the nutrition piece, but I always tell patients that there's like one thing I can tell you is really start lifting weights and building that muscle. It's so important. Patients, especially in my demographic of patients I see, are at risk of sarcopenic obesity, increased risk of frailty heading into transplant. I always like to give some, here's one recipe. I guess I took out the other ones for the sake of length, but here's a nice easy recipe for a weeknight meal that somebody might try. So if there's any questions, please feel free to reach out to me via email. I'm also pretty active on social media.
Thank you to our 3 previous presenters. I know we've run out of time and I apologize, but the information that's being presented is so important and it's so critical that we pass all of this wonderful information to our audience that we wanted to continue moving forward. So for those of you who still are with us, we wanted to move forward with Fiorella. And I know there is one question. She doesn't have a formal presentation, but she can answer this one question. Fiorella, can you tell us about MASLD initiative that the American Liver Foundation has?
Yes, thank you, Dr. Arévalo. So my name is Fiorella. I am a liver health specialist here at the American Liver Foundation. What I mainly focus is on connection to care with the patient. So our biggest initiative, public health initiative right now is our Think Liver, Think Life initiative. And if you are not familiar with it, feel free to go to our website so you can learn more about it. It started, this is our 3rd year. It's a 5-year initiative. And this is what we're hoping to achieve, is to ensure that every American understands their risk. Let me get out here. The risk for liver disease. And how do we try to accomplish this? We have MOUs with different organizations, CBOs, health departments, lots of FQHCs for testing. So the biggest component here is screening, making sure this, and it's usually, as you can tell, the list that I just mentioned, people that are usually of lower socioeconomic statuses. And after the screening is done, what is the next, what comes after that? And it will be connection to care or linkage to care for those that are more familiar with like the whole hepatitis area field. So this is very, it's a very important initiative. We make sure people know the results after they got their results from the clinics. We go over the results, and they also get a great tool, MyFitnessPal, so they're able to utilize it for recipes, among other things. They do get health information, and all patients get called. So towards the end of the conversation, patients know their status, and they know they need to follow up with a healthcare provider if we are seeing results that are not favorable. So basically, we start with when we start seeing patients that that this shows there's steatosis and beyond. And yes, so we do the follow-up, and we're really excited. We're almost close to 50 states right now. Thank you.
Great. Thank you so much. There is one more question that just came in, and I could go to all our panelists who wish to answer this. Can MASLD be prevented or avoided?
Yes. Can I pitch it? So I'm happy to answer this question. So the truth of the matter is yes, if you appropriately target your metabolic risk factors and reduce metabolic syndrome, you can prevent MASLD and MASH. And then lastly is not only can it be prevented, it can also be eliminated. So it can be cured as long as you appropriately control. And the biggest data as of this date is for weight loss. So appropriate weight loss can lead to resolution of MASLD and MASH. And this is data that comes from the bariatric surgery literature, where we see resolution of MASH and MASLD, both fibrosis and not. So both prevented and cured.
Another question came in, but I think you just probably answered that question. When people are screened and found positive for liver disease, what are the next steps to take? Is there anything else that we should consider?
Sorry, is that also for me?
Well, yeah, it's whoever wants to answer it.
Sure.
Yeah,
So
yeah,
there's definitely steps to be taken. So once someone's screened, if they are identified with MASLD without evidence of scar tissue, then those patients should be continued to aggressively treat their modifiable risk factors. For patients who have identified fibrosis, then those patients should be moved to a specialty care, in which case identifying the level of fibrosis, considering for either treatment or clinical trials, then becomes really important.
Wonderful, thank you. I don't see any other questions. Well, one more. Should we recommend metabolic surgery or bariatric surgery? And if so, how soon after diagnosis and to which population?
Yeah, I can take that one. So, bariatric surgery is definitely a tool that I utilize and support. The reality is that many patients don't have coverage for anti-obesity medications. The GLP-1 receptor agonists are exceptionally expensive. Many patients don't have time to wait, right? They have advancing disease. And I will tell you that it does take repeated kind of exposures to the conversation about bariatric surgery. Nobody's excited about surgery. That's just the reality of it. But I will tell you that my patients that have undergone surgery really don't regret the decision, as long as it's done at a center for excellence. There's longitudinal care. The paradigm is shifting that, patients used to get bariatric surgery and then just kind of get turned to their own devices after a certain amount of time. I follow my patients pre and post longitudinally. We use medication sometimes post-operatively too to help them. So anyone with a BMI greater than 35 with a comorbidity, or 40 or greater without a comorbidity, can actually undergo bariatric surgery. However, insurance may require that they are part of some sort of a program for at least 4 to 6 months prior. That's actually not in line with the guidelines. The guidelines actually say that bariatric surgery can be recommended at even a lower BMI. But this is, again, insurance has not caught up. And it depends, like, how severe is the disease, how much degree of weight loss does the patient have to benefit from? I think we have to set realistic expectations that medications that we have, although more efficacious, can only really result in 15 to 20% on average. And is that going to be, sufficient? Usually it's sufficient for a lot of people to reach that degree of weight loss and improve their cardiometabolic health. But, again, it's a marathon, and we have to kind of look at how severe the disease is and where we want to be So that's kind of a long-winded answer to your question, but I do recommend it. And many insurances actually will pay for it, even the ones that don't pay for medications.
Just quickly as an aside, in your state, because it's state specific, but does Medicaid cover bariatric surgery in your state?
So I'm in California. As far as I know, yes. They actually cover Wegovy, which is so I don't have any affiliation with Novo Nordisk, but in California, there is coverage for anti-obesity treatment for patients on Medi-Cal, which is amazing, like just amazing. Yeah.
Good. I hope other states as well. One other question: what do we do if our center doesn't have liver specialists? Well, I can try to answer that, because if it's a medically necessary and depends on the insurance, and you can go, if your center doesn't have specialists that can help the particular patient, but it's medically necessary, you can petition for out-of-network coverage in most instances, and get prior authorization for HMOs and for PPOs within most states.
I also think that general gastroenterologists are somewhat equipped to at least do the primary workup of identifying advanced fibrosis. And so I would say that even if, if your area doesn't have a dedicated hepatologist, most GI practices will have a way of assessing a fibrosis elastography or a radiology department, and they're familiar with the next steps. Once they have cirrhosis and more advanced liver care, then they usually also link to care with a directed hepatologist. So it shouldn't all fall in the hands of just a very small handful of dedicated hepatologists, but really the general gastroenterology population, because we're going to be seeing a lot more of these patients, and it's just not going to be enough specialties, specialty doctors to take care of these patients.
Another question: are you seeing roadblocks when it comes to raising awareness and or educating primary care professionals about fatty liver disease? And I want to answer that because that's one of the reasons that LPOC and LatinX Physicians of California is very, very interested, is because we have seen, unfortunately, multiple examples, and I'm in Northern California, of patients who have this condition, and unfortunately their providers have not identified that they're support for them, that there is specific diagnosis. And so we've been very active at trying to educate the community. This is number one for us. We will continue to prioritize, as you see from the data that's presented by our wonderful panel, that this is a critically important, and the information that looks at the future of liver disease, and particularly MASLD and MASH, if it's not addressed, we're looking at significant costs to our healthcare system and significant morbidity or mortality. So we are at the forefront of working to educate, and that's why our partnership with the American Liver Foundation is so important. And this is not the last, we hope, the last educational series that we're going to undertake, along with other ways to reach out our communities. We're only in California, so we're hoping that what we learned in California can be taken by the American Liver Foundation and spread across the rest of the nation, so that we can address this across the nation and eventually across the world. So we really want to thank you. And we have no time for any more questions. We've gone 15 minutes beyond our time. I want to first of all thank our presenters, who have done just an amazing job. This is recorded, so I'm going to go back and listen to it, because I know there's so much information that I want to make sure I don't miss any. And I hope you do as well. And then we will be promoting this so that if people weren't able to join us, it'll be available, the recording. And again, I want to thank the American Liver Foundation, particularly Ivory, Allison, who has done a tremendous job working with this. We're really excited about continuing to work with the American Liver Foundation, and LPOC wants to thank each and every one of you for attending. Anything else, Ivory?
Nope, that's it. You all did a wonderful job. We thank you all so very, very much. And we look forward to our second series that will be happening on next week. So please go to liverfoundation.org for more information and to register for that program. And we cannot thank Pfizer enough for sponsoring this program, as well as LatinX Physicians of California. Thank you all so very much.